Hello guys, how are you? Very good evening. Welcome to the ophthalmology session. I hope you people are doing good and you are there with your preparation for the INSET. And hello guys, how are you? Very good evening. And today we are going to do a high session for the ophthalmology questions. As INSET may the number of questions which are coming from your PYQs and PYTs are very very large. So it's about 30 to 40%. So I think that's a big percentage if you are getting directly your questions from the PYQs and PYTs, and that is up to 40%. That will be a large number, and for that matter, when we are doing the questions which are your PYQs or your PYTs, that has to be very very high yield. Let me know about my audio and video. Is it good to go? Hello everyone. Hi Gajendra, Mahendra, Yashwant, KK, welcome. Very, very good evening to all of you. Please let me know if my audio and video are good enough. Can we start, guys? So, because the recent questions are more important, and as we go away from the recent questions, they are becoming lesser and lesser ones. So we are going to start with the recent questions because they are in the upcoming trend. That means those topics are more important, and we will be talking more high level concepts about those topics as well. Hi Saurabh. Hi Hemant. So, hi Shagufta, Arshia, Anuj, everyone. Very, very good evening. So, let's start with the question number one. Which of the following is a false statement regarding a patient who is having the diminution of vision? So, there is a diminution of night vision. They are giving you history of the night blindness, and they are asking you which of the following is a false statement. So how to approach such type of question? They are giving you history of the night blindness, and they are giving you the fundus. Guys, can you tell me what is the answer for this question? It will be very very good and interactive if you also give the answer along with me. Try to see how many questions are getting right, and then we will see why they were right. Was it really right, or that was just a fluke? So let's see. So you can see this is the fundus of the retinitis pigmentosa. What is the most important thing? They have given you the history of night blindness along with a typical triad. Like we have the pale yellow waxy optic disc. This year, guys, there was a question on retinitis pigmentosa in NEET PG 2024 as well as in the INSET. So that way this will remain an important topic for your upcoming exams for the consecutive 3 years. It has been seen that if a question is coming on a topic, then consecutively 3 years question comes on it. So for the next upcoming year, retinitis pigmentosa will remain very very important. Pale yellow waxy optic disc hai. And number two, we also have the pigmentary spicules. So pigmentary spicules are present in whole of the periphery. Because it is in the periphery, so it will affect the rods, and because it is affecting the rods, therefore night blindness will not be a late feature, rather night blindness is the earliest feature. It is the earliest feature which is found in the night blindness. That is why answer will be C. Okay, what will be the third part of the triad? Third part of the triad may we are also getting the arteriolar attenuation. Arteriolar attenuation. Guys, can you tell me what is the investigation of choice for retinitis pigmentosa? Meanwhile, please comment on the investigation of choice. And most common, now they are saying that is the most common rod and cone dystrophy. So yes, it is the most common hereditary. This is hereditary. This is also pigmentary, which is affecting the Pigment epithelium, that is the RPE layer. It is most common, it is hereditary, it is pigmentary, and it is the dystrophy of the both rods and cones. But because rods are affected earlier than the cones, that is the most important thing. Therefore, night blindness will always be the earliest and not the late one. Yes, so you are very correct, you people. ERG. So ERG is the investigation of the choice. Now, why ERG is the investigation of choice? Because here we have A wave, we have B wave, as well as C wave. So, A wave will come from rods and cones. Both rods and cones are affected. It's a dystrophy of the photoreceptors, and we know rods and cones are also first order neurons. Once the rods and cones are affected, which are first order neurons, this impulse, which is going to the second order, that is the bipolar cells, that will also be affected. And B wave shows the activity of bipolar cells, that is the second order neuron, so that will also be affected. And C will affect the RP activity, and it's a pigmentary dystrophy. So very logically I can say that ERG is the investigation of choice in the patients of retinitis pigmentosa. So the whole of the topic is important. Retinitis pigmentosa most common है, pigmentary dystrophy, rods are affected earlier than the cones, ERG is the investigation of choice, its part. Now one more thing I will tell you. Very commonly what happens, that we have one more thing called as the salt and pepper retinitis. Okay, once you have made a diagnosis that it is retinitis pigmentosa, telling this question is not, difficult. But the major limiting thing is that you should know whether it is retinitis pigmentosa or it is salt and pepper retinitis. So how can we find out this? Because very often the fundus of salt and pepper retinitis is also same as that of the retinitis pigmentosa. So see, here we have salt and pepper. So here we have both white as well as the black flakes. While in the retinitis pigmentosa, you were getting mainly the pigmentary spicules which were found in the periphery. Here you are getting both, that is why it is salt and pepper. Secondly, here we will have no triad. Okay, whenever you get a question on the salt and pepper retinitis, triad will not be there. And number third, if you look at the causes of salt and pepper retinitis, mein we have the congenital rubella as well as the congenital syphilis. Now guys, if you know this, then again it will be very very helpful to you to find out whether it is salt and pepper retinitis or retinitis pigmentosa, because RP was sporadic or it was familial, but this is caused by congenital rubella syndrome. You already know the triad of congenital rubella syndrome. If that is there in your question, that you know that it is a case of salt and pepper retinitis, you know about congenital syphilis, Hutchinson's triad, interstitial keratitis, sensorineural hearing loss, then you know that it is congenital syphilis, and that will be a case of salt and pepper retinitis and not the retinitis pigmentosa. So the thing is that associated signs and symptoms will also help you to find out whether it's a RP or it is the salt and pepper retinitis. So we have done two similar things, how to differentiate between the two and what will be the causes and the presentation of the two diseases. I hope it's clear. Yes. So my aim for today is that how to find out that this is the thing, what are the things that can confuse you, and how to be sure that this is retinitis pigmentosa only and not the salt and pepper retinitis. So I hope it's clear guys. Okay. Next पे चलते हैं. We have a patient of the RHD who is coming with a superior visual field defect. Superior visual field defect है. This will be called as the superior altitudinal hemianopia. Okay, this is called as superior altitudinal hemianopia. Now whenever you get this altitudinal hemianopia, this is always found in the anterior ischemic optic neuropathy. So it is found in the vascular lesions, ischemic lesions. Now because it is a altitudinal, it is only superior, so it cannot be central defects, right? That is why we have either branch retinal artery occlusion and branch retinal vein occlusion. Now there was lot of controversy when this question was come, and I had seen many people had answered it as artery occlusion and many people had answered it as a vein occlusion. Now see, certainly because they have given you the history of RHD. RHD may we have the tendency of the thromboembolism. Okay, we are having the tendency of thromboembolism, and thromboembolism will lead to the artery occlusion. So I can see some of the people are answering as A, beta. It's not A because it is a sectoral involvement. So first of all, we can completely rule out the central artery occlusion also and vein occlusion also. We are left with the branch retinal artery occlusion या फिर branch retinal venous occlusion. Artery occlusion is the answer here because they are giving you history of RHD. RHD may we have the tendency of emboli forming thrombus embolism, and thromboembolism will go and block the artery and not the vein. That is why the answer to this question is the branch retinal artery occlusion and not the vein occlusion. I hope it's clear, guys. Yes, Saurabh. So, hi Khushi. Khushi, after the session only, I will be able to share the PDF because you want the annotated PDF that will be available on DBMCI Premier group as well as on my Telegram group. Okay, so after the session, you can find it out. Yes, till the INICET session for sure. I am not sure after that, but this will definitely be available till INICET session. Okay, so I think it's clear now. So let's move to the next question. So this question is related to the chemical injuries where a laborer is coming who is working at a construction site with the red eyes and history of tuna particles falling 1 hour back. So tuna particle injury is actually a chemical injury or a chemical burns. Whenever we have chemical burns in the eye, basically these are also the emergency conditions which can present with the acute red eye. Can you tell me the DD of acute red eye as well as the type of vision loss that can present in the patient? So whenever you have this acute red eye, we have a DD, right? The most common DD, though we are discussing it in the chemical burns, but yet chemical burns is not the most common DD of this acute red eye. Either it is acute congestive glaucoma or acute anterior uveitis. ठीक है. Now the type of vision loss that you are getting here will be the sudden as well as painful. This will be sudden as well as painful diminution of vision. So this patient of chemical injury can also present. Why indirectly I am saying? Because due to the chemical burn also, it will lead to acute anterior uveitis. We will have lot of inflammation. Due to inflammation, we have acute anterior uveitis, and therefore indirectly again it is the acute anterior uveitis which is presenting with the acute red eye. Okay. So it can be now the acid injuries also, or it can be alkalis. Hi Krishna, I could not get what are you trying to say. Alkalis injury, and it is the alkali injury which is actually more severe because you know we always have more risk of perforation. Here we have the risk of the perforation, and that is why it is the alkali injury which are more severe in comparison to the acid injury, though the treatment pattern will remain same whether it's a acid injury or whether it's alkali injury. So if you go with the treatment, because it is an emergency condition, we have to first bring back the pH. Okay, so for this we have to do the irrigation. It's very important that you have to do the irrigation of the conjunctival sac thoroughly for about 40 minutes to 60 minutes or 1 hour. Now this irrigation of the conjunctival sac can be done by the basal salt solution, which is considered to be the best. Otherwise, if this is not available, then also you can do with the normal saline or by the ringal lactate. Now of the records, if I am telling you that when it's an emergency and you have to irrigate the conjunctival sac, even if you do not have the basal salt solution, you do not have the normal saline, you do not have the ringal lactate, no problem. You can wash with the distilled water, RO water, tap water, anything, so that we are able to remove the acid particles, alkali particles, tuna particles. We have to flush the particles, we have to bring the pH back ठीक है. Even if you are in emergency, because you know inside people aims, people are very fond of asking the practical things. So the patient has come to you and you are alone, then also you can take two bottles at one time in both of your hands and prick it. I clear my ML exam, 3 stage. I got license. Your lecture helpful, ma'am. Oh, thank you so much. Heartiest congratulations. You could clear ML examination by these notes. I am humbled and I'm very, very proud of you. Very happy for you. So you can use two bottles there. You can prick with the wide bore and you can start irrigating even alone in the casualty till the time. So 15 minutes is not sufficient. Basically 30 minutes, 40 minutes, or even 60 minutes that we have to do. Once you have done, now what will be the step number 2? Step number 2 may we have to do the double eversion of the eyelid. We have to do the upper eyelid. So 2 times we have to evert it. Now you would say that we are not ophthalmologists, we cannot evert it. So you can take the support. You can take out the refill from the pen. You can put it here. You can take the stirrers, the tea stirrers. You can take the kajal pencil or the mascara pencils also. You can put here, and taking the support, you can evert it back. And once you have everted, you have to remove the deeply embedded particles. So that is very, very important, because these particles are deeply embedded and they are going into the fornix area. So it has to be removed at the earliest. Once you have done this, you have done the irrigation, the particles have gone into the eye. So obviously some amount of necrosis they have done. Hai na? So what you have to do is the removal of the dead tissue. That is the debridement. Next May we have to do the removal of the dead tissue. It is the removal of the dead tissue we have to do. Now once we have done the removal of the dead tissue, then we have to use the topical drugs. Topical drugs may, now why we are using the drugs after the debridement? Because obviously when you are putting the drugs, it will not be able to act over the dead tissue. So first you have to do the debridement, and only then we have to give the drugs. Now which drugs we have to give? What are the drugs that I can give? I have to give the steroids. Now you will say that there are chances of perforation, then why we want to give the steroids? For the congestion. There is lot of congestion, guys, so I will have to give the steroids. I will have to give the tetracycline. We can give the tetracycline or the tetracycline group of drugs, which is preventing the perforation. To prevent the perforation, we have to give this drug. You can give doxycycline, can give tetracycline, and then we also give the citrate. Citrates will be acting as the antidotes. No, all these drugs have to be given. So obviously we have to give the antibiotics because there is a risk of infection. But here the tetracyclines or the doxycyclines that we are giving, they are not just given to prevent the risk of for the infection, but also to prevent the risk of perforation. If you see in the corneal ulcers also, whenever we have bacterial ulcers, we have impending perforations, then we give the tetracycline group of drugs. So tetracyclines or doxycyclines, anything can be given. Steroids, obviously under the antibiotic cover for a limited time. In order to combat the congestion, you have to give the steroids. So while I am writing steroids, I am telling you disclaimer continuously that it has to be under the guided vigilance. And of course the citrates, which is anti-neutrophilic, anti-proteolytic, anti-collagenolitic. So a definite antidote. Hina, yeah, thank you so much, guys. Tomorrow is Karva Chauth, and that's why Hina is there. So this is whole of the topic on the chemical injuries, acid injuries hai, or the alkali injuries hai. So you can do this question now. I hope, can you see how will you manage this condition? We can easily give the irrigation with the normal saline, and we can give now, if you see, topical antibiotics have to be given, cycloplegics for pain relief can be given, patching the eye we will never do in the cases of chemical injury. uh, Tarso ref भी नहीं करेंगे. Whenever we have the risk of infection, we will never close the eye, we will never cover the eye, we will never patch the eye. But yes, here first and second is okay. Irrigation with normal saline hai, but obviously priority. Now, once we have discussed this, I will tell you one more thing. See, PYQs are important, but it's very important to tell you the practical problems that you face doing the question. So here first and second both seems to be right. So what happens when we have more tricky questions? It is actually the more close options. Questions are same more or less, but the answers, the options are getting more and more close. And that is the reason they are becoming more tricky. So even if you get a such type of a question and you have options like this, please see which one is more preferable option, the better option. Okay, so better option in terms of order, if you see, the immediate thing that you have to do is the irrigation of the normal saline, and that is why answer is A. Okay, in the paper also you might get the question where more than one option seems to be correct. Please see the order. What should be done first has to be given as the answer. Chalo. Next question. What are the, all of the following are the actions of superior oblique except? तो एक और important चीज where yes sir is lucky, even I am also lucky, है ना? तो talking about the actions of extraocular muscles, not only superior oblique muscle, I will tell you how to calculate the actions of the extraocular muscles as a whole, because you know, you can get a question relating to the actions of the extraocular muscles. So basically we have got three steps, three simple steps in which we can calculate the action of the extraocular muscles. सबसे पहले, if you go, thank you so much. You are considering me as a role model. Thank you. Thank you. So, step number one, देखो. First of all, you have to see whether it's a rectus muscle or it's a oblique muscle. ठीक है? You have to see whether it's a rectus muscle or whether it's a oblique muscle. If it is a rectus muscle, then the primary action is straight up or straight down, because the rectus muscles will always go straight in the same direction. Rectus का मतलब क्या है? Straight. Rectus means straight. So they will always go straight in the same direction. Superior rectus elevation, inferior rectus depression, medial rectus adduction and lateral rectus abduction. Squint में सबको problem रहता है. That's why I am trying to elaborate the squint. ठीक है? So we have elevation, depression, adduction, abduction. While if it is a oblique muscle, then the primary action will be either intorsion or extorsion. So the primary action can be decided in this way. Now, if I am talking about superior oblique, we are going for the oblique muscles. Therefore, either it's intorsion or it is extorsion. And you have to remember here the sin. Superiors are intorters. Therefore, the primary action will be the intorsion. Right? Primary action of superior oblique आ गया, intorsion. Then go to the step number 2. Step number 2 में हम जाते हैं. Now you have to replace their places. Primary action of rectus muscle becomes the secondary of oblique, and primary action of the oblique muscle becomes secondary of rectus. Okay, so now the secondary action of the oblique will be the primary action of the rectus muscle. So here I am writing now elevation and depression. Okay. Now how will you decide that which muscle will elevate and which muscle will depress? इसके लिए you have to see that O for oblique is actually equal for to O for opposite. O for oblique is equal to O for opposite है. So oblique muscles are always going in opposite direction. Our muscle is superior oblique. इसीलिए that will cause depression. So in this way we have got the secondary action. फिर finally आ जाते हैं step number 3 पे. Step number 3 में tertiary action is equal to rad. Another mnemonic is rad, like one was thin, another is rad, means the recti are adductors. Recti muscles are adductors, therefore oblique, the tertiary action will be abduction. So in this way, we are getting all the three actions of the oblique muscle. Can you find out the actions of inferior rectus? So in this way, guys, using the same 3 steps, can we find out the actions of the inferior rectus? Primary action means it will go straight in the same direction. Inferior rectus inferiorly jayega, so depression, okay. And secondary action will be the primary action of oblique muscle, intorsion, extorsion, and remember it is the superior which are in tortus, therefore inferior will cause extorsion. And then tertiary may we have rad, therefore recti are adductors and therefore it will cause reduction. Ye dekho. So in this way, we can easily find out the actions of the extraocular muscles without any confusion. So if you see this question now, superior oblique ka primary action is the intorsion, secondary action is the depression, and tertiary action is the abduction. ठीक है, it is the rad, recti are adductors होते हैं. This is the oblique muscle and therefore the action will be the adduction. Is that clear, guys? Action of superior oblique clear. How to find out the action of the extraocular muscles? This is an important thing and you can get this one in the upcoming examination also. How to find out the actions of the muscles. Right? Is that clear to everyone? Next question related to nerve palsies. Nerve palsies may you have to remember a very important thing, a very simple thing, that is your all three SO4 and LR6 है ना. It's very simple but very important. It is all the muscles are supplied by third cranial nerve except for the SO4 and the LR6. That means whenever we have the third nerve palsy, all the muscles are paralyzed. All extraocular muscles are paralyzed. Very good. Except, so all the muscles are paralyzed except for the SO4 and the LR6. Only these muscles are not paralyzed. Therefore, our eye is able to work in only those directions in which these muscles are working. That is your superior oblique and the lateral rectus. Now, what are the actions of superior oblique and the lateral rectus? Superior oblique, just now you have seen primary, secondary and tertiary. Primary was intorsion, right? Then secondary was depression, O for oblique and O for opposite. Then tertiary में rad, therefore recti are adductors. This will cause abduction. ठीक है? Lateral rectus will take the eye laterally. So the maximum sparing of which action will take place? It is the abduction. This is the maximum sparing of the abduction is taking place, and obviously that is why the answer will be the limitation of abduction. Rather, it is spared maximally. ठीक है ना? And eye का direction, it is in depression and abduction. So eye will be down and out. Whenever you have down and out eye, you are always sure that it's a third nerve palsy. Along with this, you have LPS palsy. LPS is the levator palpebris superioris, elevation of the eyelid. Therefore, its paralysis will lead to ptosis. Ptosis can also take place. Then we have the absent pupillary reflexes. If I talk about the pupillary reflexes, okay, pupillary reflexes are absent. Why? Because in the pupillary reactions, it is the third nerve is the efferent nerve. Efferent means effector nerve. This is the nerve which is responsible for bringing the effect, and that is why there is absence of reflexes, but there is something called as the pupillary sparing. Pupillary sparing third nerve palsy. This will take place in the diabetes and hypertension. So that means whenever third nerve palsy is taking place due to the diabetes and the hypertension, the reflexes will remain present. Guys, this is also a PYQ. Another related PYQ is that if you are getting, suppose the third nerve palsy. Okay, suppose we are getting third nerve palsy and you are getting the pupil dilated. So if I am getting dilated pupil in the third nerve palsy, that means we should have some surgical cause in the mind, and for this you can do the radio imaging. So that is another kind of PYQ that is related to the third nerve palsy. Ptosis a related question we have. Absence of the pupillary reflexes hai, pupillary sparing. This third nerve palsy is there, down and out is there, maximum sparing of the abduction, that is there, you can see. So exo means out, hypo means down, this is your down, and out eye is there, ptosis is there, absence of pupillary reflexes is there, and that is why answer is D. I hope it's very very clear. Nerve palsies as well as the movements are clear of the extraocular muscles. Another question related to proptosis. So proptosis, baby, there has been a time when 3 questions, NEET 2020 mein there were 3 questions on the proptosis at a stretch. So let's see, most common cause of proptosis in the middle age. So whenever we are talking about the adults, guys, it is always thyroid eye disease. See, when I am talking about this proptosis in children, okay, whenever I am talking about the proptosis in children, the causes are different. There you will have to see, is it unilateral proptosis or is it the bilateral proptosis? If it is unilateral proptosis, look for the orbital cellulitis. Then you have to look for orbital cellulitis. Now there are a couple of questions which are structured around this orbital cellulitis. First of all, the cause. So mainly it is due to the staph aureus. Orbital cellulitis is mainly due to the staph aureus. It is presenting with the unilateral proptosis. Usually it is not severe in itself, but yes, it can lead to an emergency that is called as the cavernous sinus thrombosis. That can be cavernous sinus thrombosis. Now, cavernous sinus thrombosis is also unilateral to start with, but it can become bilateral in about 50% of the cases, because you know it's a paired sinus. So in the beginning it can be unilateral, but it can go and become bilateral in about 50% of the cases. Moreover, there are so many nerves which are passing through the cavernous sinus. Can you tell me, guys, which nerves are passing through cavernous sinus? If you see through the center, and this is the lateral wall. Okay. Now center say we have internal carotid artery and the sixth nerve, while lateral wall say third nerve, fourth nerve, and the fifth nerve. I am not commenting on the divisions of fifth nerve. The reason is that there has been an update that in cadaver we have first and second division both, and in the living we have only first division. So let's not talk about it. We are talking about the nerves. Okay, so that means when all these nerves are passing, obviously ophthalmoplegias can take place, proptosis can take place, chemosis hai, congestion hai, everything is there. And yes, 3, 4, 5 and 6. Okay, and 6 is the first one to get affected. Due to the 6 nerve, we can also get the diplopia. We can get the diplopia in the lateral gaze. We can get the diplopia in the lateral gaze. This is the first very important manifestation that you can get. So, whenever you are getting cavernous sinus thrombosis or you are getting the diplopia in the lateral gaze, think about the other one, because sixth nerve is passing through the center of cavernous sinus, and then you can diagnose it. The diagnostic feature will be the mastoiditis. So easily you can make the diagnosis by the tenderness as the mastoid process. You can check by this, that is called as the mastoiditis. And once diagnosis is confirmed, treatment is not a problem. While if I am talking about the bilateral proptosis, so bilateral proptosis in cases of the children is mainly due to the metastasis. Alarming signal hai, think about some tumor. And usually the metastasis that is taking place is AML or the chloromas. So again, leukemias hai, or it can be the neuroblastomas, or it can be the neuroblastomas. I think we will have some question on horizontal gaze palsy and I'll talk about it. Okay? This is about the children. But when I talk about the adults, so when I talk about the proptosis in the adults, then you have to always think about the thyroid eye disease. Now, thyroid eye disease, though it is more common in females, it is more common in the middle age with the history of smoking, if that is their history of thyroid status. If I see 90% of the people will give me the hyperthyroid status. Now that is most commonly there. Okay, now we are thinking about the thyrotoxicosis or the Graves disease, but 6% of the people will also be euthyroid. That is an important thing. And even 4% of the people will also be hypothyroid. Okay, so just because the patient was having a euthyroid, 6% of the people will also be euthyroid. So just because the patient is having the euthyroid status, you cannot rule out the thyroid eye disease. That is an important thing. Um, then earliest sign. Now there is a lot of confusion that the earliest sign of the proptosis of the thyroid eye disease is proptosis. No guys, proptosis most important hai, but earliest it's not there. It has to be the upper lid retraction. Upper lid retraction is the earliest sign, followed by the proptosis. Proptosis is most common but not the earliest. That is another important thing. If I talk about the pathology of the thyroid eye disease, so it can be primary pathology, it can be secondary pathology. Primary pathology is in the orbit, and which cells are affected? It is the fibroblast, orbital fibroblast cells, and we have a lot of edema in the orbital cavity, and actually that is leading to the proptosis. While secondary pathology will take place in the extraocular muscles. Muscles are affected, and muscles may what we have is the fibrosis. Due to the fibrosis, we have the restrictive squint. So there are so many questions related to this which can be asked. We have the proptosis, we have fibroblast, then we have restrictive squint. Can you tell me the test that you can do to differentiate between the restrictive squint and the paralytic squint? Anyone can answer? The test that we can do for the differentiation between the restrictive squint and the paralytic squint. Meanwhile, I will tell you the order of the extraocular muscles. The order of the extraocular muscles which are involved is I, M, slow. This is the order of the muscles, that is inferior rectus, medial rectus, superior rectus, lateral rectus, and then is the oblique. Yes, very correct. So we can do the force duction test. With the help of force duction test, you can easily differentiate between the paralytic squint and the restrictive squint, right? A very, very important sign that you get here is the Coca-Cola bottle sign. That is important thing. Coca-Cola bottle sign you are getting on the radio imaging, and usually they will give you a word that is sparing of the tendons. Sparing of the tendons will be there. The origin and the insertion part are not involved whenever there is thyroid eye disease. So that means if you have this sparing of the origin and insertion, you have sparing of the tendons. That is again a very, very important thing that you can get in the question. See, once you know that it's a thyroid eye disease, it's not difficult to answer any question. So my focus is to get the diagnosis. So what are the things that will help you in pinching the diagnosis? You will get the sparing of tendons, you will get the fibrosis of the muscles, restrictive squint है, smoking है, euthyroid भी हो सकता है, female है, middle age है. All these things will help you in making the diagnosis. Once a diagnosis is confirmed, telling about any of the signs, about any of the treatment is not difficult. So I hope it's clear, guys, right? Then coming to the next question. Next question may patient is coming with the paresis of orbicularis oculi. We have leg of ophthalmos, we have insensitive cornea, blindness is there. Which of the following conditions may be responsible? So here we have motor paralysis, decreased corneal sensations, facial palsies, leg of ophthalmos. This is actually the leprosy. And how to do certain type of questions where we are having the systemic features also and we have ocular features. This time they have asked about the leprosy, but how to be prepared for future, how to be prepared for the further questions like this. So I hope you have this one with you, the part that I have given you as a part of your workbook also, ocular and the systemic features of immunological disorders. It's a pearl, guys, and if you do not have, then you can DM me. I will also put this one in the telegram group. This will help you like anything whenever you are having the questions on the syndromes or in inherited disorders, infectious disorders, immunological disorders, because whenever questions will come on these syndromes, it will come as a whole. They will not just ask about one aspect of the Hansen's disease or one aspect of Down syndrome or one aspect of rheumatoid arthritis. They will have a 360-degree perspective, but you are learning these parts in different subjects. So at one place we should be having all of this so that we can consolidate and integrate at the time of doing the question. So that is the answer for this. Okay, so you see, like we have rheumatoid arthritis, we have SLE, giant cell arthritis, sarcoidosis, Letter syndrome, systemic features, extraocular, intraocular, all these features are there. So if I talk about the leprosy, I will show you here in the bacterial, guys. So see, this table will help you directly. If you see the bacterial में leprosy है, thickened nerves है, hypostatic skin lesions हो गया, weakness हो गई, facial palsy, leg of ophthalmos is there. So that means this is directly giving you the answer of this question. And believe me, this is a hard core truth. If you are missing this table, you are missing something in your paper. So, though you are learning each and everything about leprosy in your systemic one, I am also teaching meteorosis and ophthalmology. But what about the integration? So, for that matter, take out the printouts of these pages, put it on your study table, and every time you are learning about leprosy, learn 360-degree perspective of leprosy. Similarly, whenever you are learning about the tuberculosis, learn about the 360-degree perspective of tuberculosis, rheumatoid arthritis, or Down syndrome, or myasthenia gravis, or Marfan syndrome, or homocystinuria. If the time will permit, I will also discuss this table. Otherwise, I will share it after the session. All right, guys. So very important one. Then coming to the next question. Screenshot का जरूरत नहीं है. You do not require the screenshot. I'll be sharing it because it has so many pages. I will share it after the session in the group. Okay. So we have a 2-month-old child. A 2-month-old child presenting with the watering of the eyes hai, and the photophobia. All of the following can cause the above symptoms except. So again, they are obsessed with the watering and photophobia. Sometimes they are asking directly about the watering and photophobia, like in Bablu. Sometimes they are asking you all except question. In one way or other, they are talking about the photophobia and the lacrimation. So if you go with the exclusion thing, number one is the why Madhu, it is A. If there is a nasolacrimal duct obstruction, so this NLD, they are asking you except, all of the following will show you except. So NLD obstruction, why it will not show watering? If there is a NLD, NLD means lacrimal duct. If this nasolacrimal duct, which is actually draining in the inferior meatus, right? So if this is obstructed, obviously we will have watering, and then we can have infection also. So obviously this can cause photophobia. Congenital glaucoma may we have BPL card, we have blepharospasm, we have photophobia, we have lacrimation. So actually may both of them are correct. It will not be found in the distichiasis. Distichiasis, when I say distichiasis, and then they are saying about the entropion. These are the lid deformities. Both of them will not give you, but if you have to choose one, then I would say you can go with the distichiasis. Entropion, we have invert turning of the lid margins. When there is invert turning of the lid margins, this can lead to trichiasis. Trichiasis means we will have the rubbing of the eyelashes, rubbing of eyelashes over the cornea, and that rubbing can lead to watering. Okay, that is why if you have to choose one, you have to choose the distichiasis. Distichiasis may we have got the 2 rows of the lashes. So if you have 2 rows of eyelashes, there is no clear cut um, evidence that you will have the watering and photophobia in the patient. That is why answer to this question is B. Entropion may we have invert turning of lid margins. Invert turning of lid margins can lead to trichiasis. Trichiasis can lead to watering. That way, that can be there. All right. Then some of the other lid deformities, like we can have the poliosis, we can have madarosis. Poliosis may we have graying of the eyelashes can be there. Then madarosis may loss of eyelashes. Loss of the eyelashes can be there. One is poliosis and one is the madarosis. So we have the different lid deformities that can be also asked separately. And like madarosis is found in the leprosy. Where is poliosis found? Can you tell me where is poliosis found? Like madarosis is found in the leprosy. Poliosis is found in the VKH syndrome. Vogt-Koyanagi-Harada syndrome. It can be a part of multi-system involvement. We have cutaneous involvement, जिसमें vitiligo है, poliosis है. Then sensorineural hearing loss, tinnitus, meningitis. There are so many syndromes. Madarosis can be a part of the leprosy. Hansen's disease can be there. Okay. Moving towards the next one, the patient 40-year-old wearing thick glasses. So thick glasses means it is suggestive of the high degree of refractive error. So that can be high myopia, and we know that high myopia is a degenerative condition and it is leading to the sudden onset of flashes. Therefore, the answer will be the retinal detachment, because whenever we have high myopia, it is also called as degenerative myopia, or it is called as the pathological myopia, or it is also called as the pathological myopia. So it's again important condition. Why it is called as pathological? Because here we are having the overstretching. Here we are having the overstretching of the eyeball. Yes. Due to the overstretching, it is called as the pathological. And this overstretching will actually lead to high degrees of the myopia. We have high degrees of myopia, and when I say that it's a high degree of myopia, it will be more than -6 diopters. We have high degrees of myopia, and this can lead to the degenerative changes. This can lead to the degenerative changes in the eyeball. So basically, high degrees of refractive error hai. Because of this high degrees of the myopia, It is also called as the high myopia. And because of the degenerative changes, it is also called as a degenerative myopia, right? So there are so many signs of this high myopia, and all of them are important. That is why we are also discussing the other signs. Like number one, if I talk about the sclera may we can have the posterior staphyloma. From the last 3 years continuously we are having the questions on sclera, and that is why posterior staphyloma is very very important, guys. So if this is the eyeball, there will be the posterior ectasia of the eyeball. This posterior protrusion or posterior ectasia is called as the posterior staphyloma. And then changes can be in the choroid. Changes can be in the choroid. Now because choroid vascular hai, that is why we can have the hemorrhages also. Hemorrhages will be called as the fossa fuchs spots, that can be there. We can have very correct, Rahil, lacquer cracks can also be there, breaks or cracks can be there, that is also there. Then after the choroid we can have the changes in the retina. So in the retina, we can have the peripheral degenerations, and because it is basically affecting the periphery of the retina, that is why rods are affected. And because rods are affected, that is why this patient can present with the night blindness. Now one more thing, guys, those who have attended my class already know that I believe in DDs, because this will help you a lot in doing the clinical scenarios. So if you are one who is attending this for the first time, if you are not a DBMCI student, guys, please always try to highlight your DDs. You can make a separate list also of all the DDs which are there. And if you are my student, you have already taken notes from me, you already have the list of the DDs. Please read them several times. Please add them to your 20th notebook. Please, you can make a separate list of these DDs. You can stick it on a paper on your study table, because if you already know the DDs, solving the clinical scenarios will become a piece of cakewalk and very very easy. Okay, so night blindness, now this is another DD of night blindness. So if my patient is coming with the night blindness, one of the things can be this: because of the retinal degeneration, we can have the retinal holes, and due to the retinal hole we can have the RRD, that is the most important complication of eye myopia. And RRD can actually lead to the flashes of light. Now instead of saying the flashes, link of DD क्या है, they are there in the notes. Okay, I do not have any link for that. Flashes of light hai, so in the history they can give you the flashes of light, or one more thing that they can give, that is your curtain like effect, that can also be there. We can also have the curtain like effect. We can have the flashes of light, or we can have the curtain like effect. That is very very important for your trachmatogenous retinal detachment, the most common type of retinal detachment also, right guys? Then coming to the next one, anisometropia. N-iso means different, and metropia means the refractive power. Therefore, the answer is A, difference in the refractive power. Different in the color of the iris. This is called as heterochromia. This is called as heterochromia. Then one is your N-isocoria. So while color of the iris is different, then that is called as heterochromia, and anisocoria will be the difference in the size of the pupil. Difference in the size of the pupil of the two eyes is called as anisocoria. And another thing is the anisoconia. Anisoconia will be the difference. This will be the difference in the size of the image. So whenever we have anisometropia, we have the difference in the refractive power. This will always lead to anisoconia. Anisoconia means difference in the size of the images and up to 5%. If this anisoconia is up to 5%, then this is considered to be similar. If this anisocoria is up to conia is up to 5%, that means if the two images are different up to 5%, you can consider them as similar, and more than 5% they are not similar. And when these images are not similar, there will be no fusion. Then there is no fusion and there will be diplopia. So that is why it is very important that the difference in the refractive error of the two eyes are not different with a very large amount, because if they are different by very large amount, the changes in the size of the image will be very different. Then they will become dissimilar and therefore there will be diplopia. So I hope you have understood, guys. Have you understood this? Now, one more thing I would help you. Whenever you are having the question on anisocoria, okay, when you have the question on anisocoria, then how can you solve it? If you are knowing this flow chart, then you are able to solve so many questions. So difference in the size of the pupil है. You have to see whether it is increasing in the dark conditions or it is increasing in the light. Okay, you have to see that when the patient goes in the dark, then it is increasing, or when the patient goes in the light. If the patient goes in the dark and then it is increasing, that means it is a case of the Horner syndrome. Then it is a case of Horner syndrome. This was asked in AIMS 2020, right? While when patient goes in the light, then it is increasing. Then you have to see the shape of the pupil. Then you have to check the shape of the pupil. There can be two things. It can be normal or it can be abnormal. Okay. So if it is abnormal, then it can be a case of trauma. But if it is normal, then you will have to give a constricting agent. So we will give the 0.1% pilocarpine. This is the dilute pilocarpine, and dilute pilocarpine के बाद you have to check for the constriction. So you have to see that constriction present or absent. Okay, if the constriction is present, now very important. There was a AIMS question related to this also, where they had said which of the following are used to find out the diagnosis के लिए. Diagnosis में there are two kinds of pilocarpine. One is 0.1% pilocarpine and one is 1% pilocarpine. So 0.1% pilocarpine से only one kind of pupil gets constricted, and that is the Eddy's tonic pupil. It is the Eddy's tonic pupil. While if it is absent, then you can give the 1% pilocarpine. Now, once you give this 1% pilocarpine, then again you will have to check the constriction. Is it present or absent? Okay. If it is present now, that means it will be a third nerve palsy. And if it is absent, then we will have the pharmacological blockade. So there are so many questions which can be solved from here. If you see, there are so many questions which can be solved. So we have the third nerve palsy, we have got pharmacological blockade, we have Eddy's tonic pupil, then we have trauma, and number 5 is the Horner syndrome. All these questions can be solved from here. Once you have done this one, then one question is what is an isocoria? That is the most simple question. Uske alawa, we can do so many questions while doing this flowchart. Right, guys? Now coming to the next one. Next question says that we have a 80-year-old patient who is presenting with the painful red eye. Painful red eye. That means it's a acute red eye. Okay. And I have already told you that acute red eye can be due to acute anterior uveitis or it can be acute congestive glaucoma. We will see what is the cause here. And now they are saying that there is a corneal edema, flare here, deep anterior chamber and cataractous lens in the right eye. So the right eye is showing you cataract, and this cataract has led to the acute anterior uveitis because we have flare, we have got deep anterior chamber. Deep anterior chamber will not be due to glaucoma. Obviously it will be due to the uveitis because here we have the miotic pupil. So now, which type of cataract can lead to uveitis, first of all, which can lead to the flare, which can lead to the deep anterior chamber, along with the glaucoma also, because this patient is having the 50 of mercury IOP, and in the left eye, it's very high, and right eye mein it's okay. So what is the most likely diagnosis? Because guys, we are having the cataract in the right eye and it has led to the flare, it has led to the deep anterior chamber, and we have the deep anterior chamber. Therefore, it is not the immature senile cataract, because immature senile cataract will lead to the phacomorphic. This will lead to the phacomorphic glaucoma, and phacomorphic glaucoma will not have the deep anterior chamber. Then another type of glaucoma that we can have is by the Morgagnian type of the hypermature senile cataract, or we can have the sclerotic type. So in both the varieties, it will be chalky white in color or it will be the milky white in color. In the Morgagnian, we have the lysis of the cortex proteins. Here we have the lysis of the cortex proteins. Due to the lysis, nucleus will settle at the bottom and these cortex proteins will cause the trabecular blockade. Now once they have got the trabecular blockade, it will cause the open angle glaucoma, secondary open angle glaucoma, and secondary open angle glaucoma means there will be deep anterior chamber. This glaucoma is called as the phacolytic because it is due to the lysis of the cortex proteins. Therefore, this glaucoma is called as phacolytic glaucoma. And what about the uveitis? So, these proteins which are released are actually antigenic proteins. Because these proteins are antigenic, they contain the sequestered antigens, therefore they can induce the uveitis. And that uveitis can actually show you the flare as well as the deep anterior chamber. So when we have open angle glaucoma, we will have normal anterior chamber. When we have angle closure glaucoma, we will have narrow angle of anterior chamber. And when we have got the uveitis, it is a deep anterior chamber. So basically it is the phacolytic glaucoma, which will also be accompanied with the phacogenic uveitis. This uveitis is called as the phacogenic uveitis, and that is why we are having the flare and the deep anterior chamber. That is the reason that answer to this question is the phacolytic glaucoma. This phacomorphic glaucoma, which is found in the immature senile cataract, cannot be there because here we have the swollen lens. Swollen lens is obstructing the aqueous outflow. So obviously we cannot have deep anterior chamber. Here we have no deep anterior chamber. Malignant glaucoma. Malignant glaucoma cannot be there because this glaucoma takes place after the intraocular surgery. So there is no history of intraocular surgery. Rather, they are saying that there is a cataractous lens. And fuchs hydrochromic iridocyclitis may there is no cataract here, and rather here we have difference in the iris color of the both sides. That is why it is called as the heterochromic iridocyclitis. So that is clear cut, not an option. So your answer is A. I hope it's very clear. If there is any doubt, feel free to put it in your comment section so that I can discuss that doubt also. So when you do it in your exam, that doubt is cleared, and therefore you can go with the right option, guys. Okay. Then a direct question, this instrument is used in. So basically this is how can IOP so high in open angle glaucoma? Why not? What happens, guys? This is the late stage of the cataract in the hypermature senile cataract, when we have a lot of proteins and slowly and gradually they have caused a trabecular blockage, so we can have high glaucoma. Most of the time we do not have very high because it is developing slowly, but here it is developed as a complication due to the sudden leakage of the cortex proteins, which is blocked, 90% blocked of the aqueous humor, because 90% of the aqueous humor passes through trabecular meshwork. So obviously we can have high glaucoma here. Okay, so this is actually the Hertel's exophthalmometer. We have already talked about proptosis. Exophthalmometer is there, and this is helping to find out the proptosis. So answer to this question is this, and it is the Hertel's exophthalmometer, which is used in the adults. This is used in the adults, while another one is the Lude's exophthalmometer, which is used in the children. For the cataract, basically we are using the slit lamp examination, and for the squint we are using the syneptophore. Here we are using the syneptophore, and for the stereopsis के लिए we are using the Titmus fly test. You should know the other names also. Titmus fly test we are using here. All right. So I think this is a easy one. We have already talked about the proptosis. Now comes this one, again an important one, how to solve the questions related to the astigmatism. Now, before we actually go to the astigmatism question, I would like to give you a brief out about astigmatism. What is astigmatism? So whenever my patient is having the uneven refractive surface are two, one is the cornea and one is the lens. So any of the surface is uneven, then the refractive power in the two meridians, one is horizontal and one is vertical, the refractive power in the two meridians will always be different. So when we have different powers in the different meridians, that is called as astigmatism. Okay, it can be the regular astigmatism, or it can be irregular astigmatism. In our scope, it is mainly the regular astigmatism, where the two meridians, vertical and horizontal, are perpendicular to each other. If both the meridians are perpendicular to each other, they have an angle of 90 degree, then I would call it as a regular astigmatism. While if they are not perpendicular, then I would say it is a irregular astigmatism. Now once you know that it is a case of regular astigmatism, we can further divide this into with the rule astigmatism and the against the rule astigmatism. With the rule, that means when the vertical power is more than the horizontal power, then it is called as with the rule, while horizontal power more than the vertical power, then it is called as against the rule. Now how to find out that which power is more? इसके लिए we have simple thing that minus power is more than 0 and 0 power is more than plus. So this is the order here. Minus power is more than 0 power and 0 power is more than the plus power. So if you have to compare between minus and 0, it will be minus which is more. If you have to compare between 0 and plus, then it is 0 which is more, and plus and minus, then it is the minus which is more. Now suppose we have the same signs on both the sides, then you have to remember that. Thank you Saurabh. I am happy that you are able to do the questions of astigmatism from my videos. I'm really very happy for you. So more the minus sign, you have to see more the minus sign, more is the power. So whenever you have to compare in the minus signs, we will see that more is the minus sign, more power. So if I have to see between -3 and -5, One having more minus sign will have more power, while we will have opposite for the plus sign. Lesser the plus sign, then more is the power. ठीक है? So if you have to compare between +3 and +5, so one having +3, which one is having the lesser plus will have the more power. So once you know this basic thing, only then it will be possible to solve the questions. Then also you should know that this regular astigmatism can be differentiated into the simple astigmatism. Then we have compound astigmatism, and then third will be the mixed astigmatism. Okay, simple astigmatism is simple, as the name suggests. On one side we have zero power, other side पे either minus power or plus power. ठीक है, so one side zero power है, then it is simple astigmatism. Other side minus, zero के साथ minus, simple myopic. One side zero है, one side plus, so it will be simple hypermetropic astigmatism. While if we are having both minus or both plus, different of the power but signs are same, then it is compound myopic or compound hypermetropic. Finally mixed astigmatism है, जिसमें one will be minus and one will be plus. So if we have minus sign on one side and plus sign on the other side, if the patient is myopic in one meridian and hypermetropic in the another meridian, then it is the mixed astigmatism. So this is how we can divide the different kinds of astigmatism. Now we will be talking about how to solve the questions related to astigmatism. 8-year-old boy hai, he was not able to see the blackboard. So he is not able to see the blackboard. That means talking about the distant vision. He is not able to see the distant object. So we are thinking about the myopia. And if you look at the retinoscopy, the retinoscopy is -1 diopter spherical, -2 diopter cylinder at 180 degree. So how to solve this question, guys? If I talk about the two meridians, we are having the two meridians here. One is this vertical meridian and one is the horizontal meridian. Now please see very carefully how to solve this question. One having the diopter spherical. Spherical component means equal in all the meridians. So we have -1 here also and we have -1 here also. Okay, now we have -2. -2 you are giving at 180. When you are giving at 180, it will act at 90. ऐसा क्यों? Because the power of the cylinders will always act at a perpendicular axis. So if I am giving at 180, then it will act at 90. So -2 here. Because it is given at 180, so it will act at 90. So now it will become -3 and -1. ठीक है? Now we are having both minus. So this will become compound myopic astigmatism, and -3 will be more than the -1. So vertical more than horizontal है. Therefore it is with the rule. Please see everyone, have you understood how to do this question? Because again we are expecting this type of question. Actually I was expecting this type of question this year only, but this year they had a lot of other googlies that they had done, so they had not done with the astigmatism. Because last year there was a theoretical question on astigmatism, terms quinoid. So this year has to be a numerical year for the astigmatism. Somehow it has not come, so definitely a high predictor questions for the NEET PG 2025 as well as the upcoming INSET examination. So it is with the rule, compound myopic with the rule. Please see if you have understood, and if you have any doubt related to this, please let me know. One more example, all right? So let's take one more example. -2 diopter spherical and +2 diopter cylinder at 90 degree. Those who have understood can solve, and those who have not understood, please see here. ये देखो, we have -2 here also and -2 here also. Diopter spherical hai, because it is diopter spherical, so it will act equal in both the meridians. And +2 you are giving at 90 degree. Because we are giving +2 at 90, so it will act at 180. So 180 pe I have added. Okay, so -2 and +2 will cancel out, and now this becomes -2 and 0. Can you tell me about the astigmatism now? -2 and 0. So this will become simple myopic astigmatism, and minus is more than 0. So this is also with the rule. So this is also with the rule astigmatism. Then minus 3 diopter spherical and minus 2 diopter cylinder at 90 degree. Solve this, doctor. Solve this now. Can you see this question? Here we have minus 3 here also and minus 3 here also because 3 is spherical. Then minus 2 cylinder because you are giving at 90, so it will act at 180. Okay. So minus 2 is acting at 180. Now this becomes minus 3 and minus 5. So minus minus means compound myopic and minus 5 will be more than minus 3. More the minus sign, more is the myopia, more is the power. So it is against the rule. You wanted me to give against the rule example. This is there. Is it okay now? Have you understood? Have you understood now, everyone? Right. Now coming to the next question, a man who is having the history of diabetes coming with a vision of 6 by 6 classified as severe NPDR, which of the following is not a feature? So first of all, whenever I am classifying NPDR, what are the characteristics that you have to look at? That is called as 4-2-1 rule. This rule is called as 4-2-1 rule, where we have all four quadrants showing the microaneurysms, and then number 2, at least 2 quadrants में we have the venous changes or venous beading is there, and at least 1 quadrant में we have the irma. So that is all 4 quadrants में we should have microaneurysms, at least 2 quadrants में venous beading है, 1 quadrant में irma, that is the intraretinal microvascular abnormalities that is there. So if you look at this, if we have at least one criteria, so if we have at least one criteria, then this is called as severe NPDR. Okay, any one of them is present, then it is called as severe NPDR. And any two criteria present, then I will say very severe NPDR. So in this way, we can classify NPDR into severe NPDR as well as very severe NPDR. If only one criteria out of these three are present, then it is called as severe NPDR, and at least 2 criteria are present, then I will call it as a very severe NPDR. Here, so we have intraretinal microvascular abnormalities hai, venous changes hai, as well as we have got the microaneurysms. So though they have given you microvascular, disc neovascularization is also not a very good option. We should have the microaneurysm, but so retinal hemorrhages is okay. Retinal hemorrhages are your microaneurysms. So answer will be the C, that is disc neovascularization. This is the criteria of the PDR. It is the hallmark of the proliferative diabetic disease. That is why the answer is the disc neovascularization. While the hallmark of NPDR as well as diabetic retinopathy as a whole is a microaneurysm, the hallmark of PDR is the disc neovascularization, or it can be the neovascularization elsewhere also. Next question, you have to identify the filter, dye and the condition. So this is, I think, very clear cut. You can see it's a fluorescein dye which is having the cobalt blue filter, and this is used for the corneal ulcers, whether it's a dendritic ulcers or it is superficial punctate keratitis. It can be bacterial ulcer, it can be fungal ulcer, any kind of the ulcers. Even in the Goldman's applanation tonometry also, where we are using the Imbert Fick law, There also we are using the same stain as well as same filter. There is no problem here, I think. That is a direct question, you can see. Okay. Then coming to the next question. So somebody was asking also about this question. The patient who is a known case of the multiple sclerosis as coming with the diplopia looking towards the right, and convergence is normal. So what is this? Because multiple sclerosis is a demyelinating disorder. It's a demyelinating disorder, and a demyelinating disorder can lead to the MLF lesion or internuclear ophthalmoplegia. Now, I will tell you a very, very simple rule for solving the questions related to the INO or the MLF lesions. Okay, na? It is actually called as the internuclear. This is called as internuclear ophthalmoplegia. So internuclear is between the third nucleus as well as the sixth nucleus. So these MLF fibers are actually joining the two nucleus, and these nucleus are the third nerve nucleus and the sixth nerve nucleus. So whenever we have MLF lesion or we have internuclear ophthalmoplegia, you can go by the simple formula that we have ipsilateral adduction deficit. Okay, I am not going into the details of its whole nuclear mechanism, but I am telling you the direct formula that you can apply to do that question. And we have contralateral abduction nystagmus. Contralateral abduction nystagmus है. So we have adduction deficit on the same side, and we have the abduction nystagmus on the other side. Now if you see this patient who is looking towards the right here, and he is not having any adduction in the left eye, so it is actually therefore it is the left adduction deficit. So once we know that it is the left adduction deficit, while here we are having the abduction, that means we will have ipsilateral defects. That is why the answer to this question is the left MLF lesion. So very clearly, whichever side MLF lesion is there, whichever side internuclear ophthalmoplegia is there, that side adduction deficit, contralateral abduction nystagmus. Very, very clear cut. Okay, is that clear, guys? Similar to this, one more thing I would like to tell you. When we have the junctional scotomas, once we have the junctional scotomas, where we are having the lesion at the junction, where we are having the lesion at the junction of the optic nerve and the optic chiasma. So in this question also you can do the direct one by putting the formula that whenever we have junctional scotoma, we have the ipsilateral central scotomas. We have the ipsilateral central scotomas, and contralateral we will have the supratemporal quadrant anopias. Again, what is the reason? We are not going into the details. Same side pe, if I show you, you will have something like this. We will have the central scotomas on the same side, and on the other side we will have the something like this. I can divide this into 4. So on the other side we will have supratemporal quadrant anopia. So whenever they are giving you something like this, that means it is a junctional scotoma. In junctional scotoma ka question you can do like this. Yes, if you are doing this video by the topic wise, है ना? Because questions won't repeat, but this topic as a whole will repeat. So if you are able to cover these topics, then obviously it will be sufficient. Okay. So whenever, now one thing more, guys, that does not mean that junctional scotoma may we have only the loss of central vision. There will be loss of the full vision. because optic nerve is responsible for the total vision loss, but because it is representing the central vision, that is why we have central photomas. Other side ka only supratemporal quadrant enopia. So we can easily do this question in this manner whenever you have a question related to your internuclear ophthalmoplegia, or you have question which is related to the junctional scotoma, we can do it something like this. Sleeping curly, why you have not touched ophthalmology till now? And even if you have not touched ophthalmology and you want to sit for this INICET paper, just write down all the topics that we have discussed today and read them again and again. Do these questions. You can take the help of one shot session. That is again very, very high yield, and you will be having that pen and turn performance in ophthalmology. Okay, now another question which these people had given, and there's a lot of controversy on this question, ki, which of the following order of the die is used. So, in the classes also, students have asked me this so many times. So, guys, there is no logical sequence of the dies, because nowhere in the textbooks or any of the journals it is mentioned that at one time we are using three dies and what should be the order. And actually, that does not make a sense that. We are using all the dies at one time, but still, because they had asked this question, the most logical sequence that I can talk about is the fluorescein stain being used first. And actually, we should be using the rose bengal staining in the last, because rose bengal is used for the dead and devitalized tissue. But here I cannot see any of these, so I can give you separately. It is the fluorescein first, then it is the lissamine. Okay, and maybe this is due to the recall. We have not got the right answer here. And then we have the rose bengal. This is the most logical sequence out of the options which are given. But I hope this question does not come again, does not make a sense. But still, because it's a PYQ, and sometimes PYQs are repeated as it is also, that's why I have given you the answer, right, guys? Okay. Why fluorescein first? Fluorescein first because whenever you have anything on cornea, even if you have some small, erosion, then also you that defect, superficial punctate keratitis defect also, then you can stain it by fluorescein. That is the first dye that we are always using. That is why. Okay. Okay, now see this question. This type of a question has come up two times in the INSET paper when we had to differentiate between scleritis, episcleritis in the patient depending upon the blanching. So, with the administration of the phenylephrine, they are saying this is the red one, and then we have the pale, you can see. So, that means blanching is present. If the blanching is present by the administration of the phenylephrine, therefore it is actually the episcleritis and not scleritis. Okay, there is no option of nodular. Follicular is always nodular only. Conjunctivitis is not there. Conjunctivitis ke liye they have to give you a discharge, that is not there. And there are so many actually differences between the episcleritis and scleritis, one of which is blanching. So let's see the other differences also between the episcleritis and scleritis. Episcleritis, first of all, is superficial, and scleritis is deeper. Okay, so all the differences that we are discussing between them is based on the superficial and deep. Like this is painless. So whenever we have the episcleritis, it will be painless. They are not talking about pain here, but in cases of the scleritis, it is very, very painful. Like you cannot have a question of scleritis without pain. Deep boring pain is there, and usually they will say that patient wakes up from the sleep due to the pain. So pain is again very, very prominent. Then number three, color. Here, the color will be bright red because it is episcleritis. Scleritis may it is deeper, so it is bluish color, violet color. That will be there. While if I talk about the scleral edema, because it is in the episcleritis, so scleral edema will be absent in cases of episcleritis, while in cases of scleritis it is present because it is in the sclera itself. And last but not the least, we are talking about the blanching. So if I am talking about the blanching, it is present in superficial but it is absent. We are using the phenylephrine for this. So if you are going with these options, definitely you will be able to solve them. Both are more common in females, both have diffuse variety more common, both have the diffuse variety which is more common, and both can be associated with the connective tissue disorders. Both can be associated with the connective tissue disorders, but obviously it will be more common in cases of scleritis, especially the rheumatoid arthritis. Now if I talk about rheumatoid arthritis as a whole, again this is very very important, where the patient can come up with the dry eyes. Along with this, we can have episcleritis as well as the scleritis also. So whenever you are solving a question on the rheumatoid arthritis and you have to see for the ocular features also, please focus on dry eyes, focus on episcleritis, scleritis, and not the staphylomas. All right, is that clear, guys? I hope the differences are clear between the two. Now coming to the next question, they are saying what is the earliest change on the perimetry. So we have a lot of the visual field defects in the glaucoma, and we have a simple mnemonic to find out all the visual field defects, like that is in corona, BP. In corona, BP should be doubly tested. I hope ophthalmology is the most doable subject for all of you, and you do not have a problem. Like, I feel guilty when any student has a problem in ophthalmology. It's my duty to make ophthalmology the most palatable subject. At least I can relieve you from one subject. Whenever you think about ophthalmology, it brings a smile on your face. You say, no, that is okay, I can do it, let's talk about the other subjects now. That is the sole aim of my as a teacher. Okay, all right, so let's talk about the visual field defects. This is the order of the visual field defects. You can see this is a simple mnemonic. So first will be the isopter contraction. First is the isopter contraction. Then we have B for the bearing of the blind spot. Then we have P for paracentral scotoma. So this is actually the earliest significant. This is the earliest significant scotoma that we are getting. Then we have the next one. Next is the siddle scotoma. This siddle scotoma is the sickle cell shape. It is the sickle cell shaped scotoma. Whenever they are asking you the sickle cell shaped scotoma, it is this. Then next is the Jerem scotoma. Jerem scotoma is also called as the arcuate scotoma, right? While doubly say we have double arcuate. This is the double arcuate scotoma. So one is the arcuate scotoma and one is a double arcuate scotoma. And due to the unequal contraction of the arcs, because we have two arcuate scotoma, we can have the Roini's central nasal step. Roini's central nasal step pattern that is formed. Then we have tested 2 times T-HEP, T for tunnel vision. This patient comes with the tunnel vision, so it is coming under the DD of tunnel vision also. And T for temporal. We have the temporal visual field is last to go. temporal visual field is last to go. This is also a direct PYQ of 2018. So there are so many questions that can be solved from here. You can see Rohini central nasal step is also PYQ. Temporal field is last to go. Which one is first to go? Then we have Jerem's area. We have earliest visual field defect. Then we have sickle cell shaped defect and whole of the order also. And even you should also know the Jerem's area. What is the Jerem's area? Jerem's area is the area which is most sensitive to the glaucoma. Most sensitive to the changes of glaucoma, which is 10 to 20 degree temporal fibers. 10 degree to 20 degree temporal fibers हैं. They are more sensitive to glaucoma. This is called as the Jerem's area. So I hope you have understood. Yes, scleromalacia perforans in rheumatoid arthritis. It can be a type of scleritis which is common in the rheumatoid arthritis. Then a very easy question, which of the following is not a feature of complicated cataract? So obviously the answer is the Krukenberg spindles, because here we know that Krukenberg spindles are actually the pigments. These are the pigments on the posterior surface of the cornea. These are the pigments found in the posterior surface of the cornea, and where they are found? They are found in the pigmentary glaucoma. So it is a finding of pigmentary glaucoma, not the complicated cataract. Another important thing is that this complicated cataract is the posterior subcapsular cataract. So posterior subcapsular cataract is visually most handicapping type of cataract, where we have maximum diminution of vision that is taking place. And that is why you should know the causes of the posterior subcapsular cataract. What are the causes of posterior subcapsular cataract? For this, we have a simple mnemonic again. I got a BSc. So PSC के लिए I got a PSC. ठीक है? So I for ionizing radiations. And then we have G for glass blowers cataract, which is occurring due to the infrared rays. Then A for atopic dermatitis. Atopic dermatitis है, which is giving you the shield cataract. Then we have B for busulfan. Then we have S for the steroids, and then we have C for the chloroquine. Even the drugs can cause the posterior subcapsular cataract. Then C for, just now you have seen C for complicated cataract. Complicated cataract, and also we have C for Christmas tree. C for Christmas tree cataract. So you can simply remember this mnemonic, and you know all the causes of posterior subcapsular cataract, what all history should be ruled out in this patient. We can solve those kind of questions too, right? Another question, which of the following is not a feature of pterygium? So first of all, what is a pterygium? Pterygium is formed from the word pterygos. It is formed from the word pterygos, and pterygos means we have wing shaped fold. So here we have the wing shaped fold of the conjunctiva over the cornea. We are having the wing-shaped fold of the conjunctiva over the cornea. So basically it is making the uneven surface, and because of this uneven surface, guys, we will have the astigmatism. So another important question, that it can cause the astigmatism, especially with the rule astigmatism, and This witherul astigmatism will be the most common cause of the diminution of vision in the patients of the pterygium. It can be of two types, as you can see. Like we have the two types, one is progressive and one is regressive. So one we have a progressive type and one is the regressive type. The progressive one can cause the obstruction of the pupil, and that obstruction of the pupil can also cause diminution of vision. But when they are asking you the most common cause, that remains astigmatism only, because every pterygium will press the cornea, will cause the astigmatism, but every pterygium will not cause the obstruction of the pupil. Parts, you can see this is okay. We have this one is the head part, then we have the neck part, and this is the body part. We have one, we have two, and we have three. And it consists of two kind of changes. If I talk about the changes in the pterygium, we have both hyperplastic changes are also there, and we have the degenerative changes are also there. The type of degeneration is the elastotic type of degeneration, that is also true. So the treatment of choice is actually the surgical excision. Therefore, the treatment of choice is surgical excision. Now here comes your question. Surgical excision you have to give as a treatment of choice, but 30 to 80% chances of recurrence are there. So in order to reduce this recurrence, what all we can use is mitomycin C. We can use the thiotepa. We can emit the beta radiations. We can also use the conjunctival autograft, and even the amniotic membrane grafting. So there are so many things that we can use. The basic purpose is that we don't have to leave that area raw. If you are doing the Bayer sclera technique, obviously the chances of recurrence are very high. So there are 30 to 80% chances of recurrence. That is why the answer is A. It is not reducing the recurrence by 95%. Rather, it is having 30 to 80% chances of recurrence. Another important thing is the Stalker's line. Stalker's line is also important in the pterygium, where we have the iron deposition. If we have the iron deposition in the pterygium, then that is called as the Stalker's line. So because pterygium is important, so I have discussed whole as a topic. I hope you have understood it, guys. Okay, now see the next question. What is true regarding optic neuritis? So this was one question where they had included whole of the optic neuritis. One of the option is on the causes, one from symptom, one from sign, and one from the treatment. And if you read that the first option, that one is correct. RAPD. RAPD is also called as the Marcus gun pupil. This is the Marcus gun pupil, and this is occurring as the earliest manifestation. It is occurring as the earliest manifestation of the optic nerve diseases, and that is why this one is the answer. There is no pain, that is wrong. It is associated with the painful ocular movements. It is associated with the painful ocular movements. Multiple myeloma is not the common cause. It is actually the multiple sclerosis. That is the most common cause, and oral steroids are not the mainstay of treatment. Rather, it is the IV steroids which is the mainstay of treatment. Marcus gun pupil, RAPD, is the earliest manifestation, and we are doing the testing by the swinging flashlight test. The name of the test will be the swinging flashlight test, and whenever we are doing the swinging flashlight test, we are getting the paradoxical dilatation of the pupils. We are getting the paradoxical dilatation of the pupils. Okay. Coming to the next question, atropine is contraindicated in which of the following conditions? So let us see options one by one. Acute congestive glaucoma may obviously it is contraindicated. Acute anterior uveitis may it is the drug of choice. Corneal ulcers may again we are given due to the acute anterior uveitis, especially when we are talking about bacterial ulcer or the fungal ulcer, because both will are affecting the cornea, so they are affecting the nerves, so we have pain. So for the associated uveitis and the pain relief, we are giving this malignant melanoma may again it is the drug of choice. That is why answer to this question is A. Acute congestive glaucoma may atropine is contraindicated because the dilatation of the pupil, because the dilatation of the pupil can precipitate the attack of the acute congestive glaucoma, and therefore myotic or the pilocarpine is the drug of choice. So out of the four conditions where your atropine is contraindicated is this one. Talking about the malignant glaucoma. So malignant glaucoma is also called as the ciliary block glaucoma. Okay. Or this is also called as the inverse glaucoma. This is also called as the inverse glaucoma. So it is the only glaucoma where we are using atropine, and that is why it is called as inverse glaucoma, which is taking place after the intraocular surgery. And we know that most common intraocular surgery is the cataract surgery or the glaucoma surgeries. This will lead to the ciliolenticular block. So whenever there is a misdirection of the ciliary processes due after the intraocular surgery, there is a ciliary block, then it can lead to the aqueous collection in the vitreous cavity, and due to the aqueous collection in the vitreous cavity, it can actually lead to a malignant condition. We are not able to treat it because aqueous drainage is taking place in the anterior segment, and that is why it is called as malignant glaucoma. And because atropine is used as a treatment of choice, it is also called as inverse glaucoma. So many of you, if you are not knowing about the malignant glaucoma, I have talked about it. Now you know about this glaucoma and how atropine is helping in opening the ciliolenticular block, and that's why it's a drug of choice. Next is what are the nerves which are involved in the oculocephalic reflex. So the nerves which are involved are your 3, 6 and 8 nerves. Basically oculo. So we have got the head tilt here. Whenever we are tilting the head, we are having the balance problem, which will be going to the eighth. है ना? Whenever we are tilting the head to one side, our balance is affected. That is affecting the eighth nerve, which will lead to the impulse to the third nerve and the sixth nerve. So whenever I am tilting my head on one side, eyes are going on the opposite side. This will go inward. This is third nerve. This is going outward. So this is sixth nerve. So in total, we have got 3, 6 and 8 nerve which are affected. So answer will be C here. Okay, guys. Now, this is again a direct question. Which of the following is not a feature of keratoconus? So, you can clear cut say that answer is harp stria, because harp stria, H for harp and H for horizontal. These are the horizontal striations which are found in the congenital glaucoma or the ophthalmos. You can see H for harp and H for horizontal. Remaining all are found in the keratoconus. Instead of this kind of cornea, you are getting this kind of cornea. So we have the irregular surface. Due to the irregular surface, we have irregular astigmatism. Due to the astigmatism, we have scissor reflex. Then we also have the Munson sign. Munson sign is what? This is actually the localized bulging of the lower eyelid when the patient looks in the downward gaze. So due to the conical corneas, there is a localized bulging of the lower lid. This is in the downward gaze. Okay. that is called as the Munson sign, that is also found in keratoconus. And you should also know that here we get the walk stria. Here we are getting the walk stria where V for walked and V for vertical. So here we are getting the vertical striations in the cornea, while H for half and H for horizontal. There you were getting the horizontal in congenital glaucoma. These are V for walked and V for vertical, that is found in keratoconus, H for half and H for horizontal found in the congenital glaucoma. Now see this question, we are having a farmer who is coming with pain, discharge, and he is also having an injury with the leaf. Now they are giving you actually the history of the vegetative trauma. Whenever they are giving you history of vegetative trauma, it can lead to the fungal corneal ulcer or the fungal keratitis. Okay? And in the fungal keratitis, it is actually signs which are much more than the symptoms. And they have shown you one sign here. This sign is, you can see hypopyon, where we have pus in the anterior chamber. While hyphema is the blood in the anterior chamber, and this hyphema can occur due to the surgery or it can be due to trauma. While aqueous flare means we will have the haziness or we have turbidity, while arch line is found in the trachoma. So it's very clear cut. So answer is a hypopyon. Therefore, answer is hypopyon. Now, another important thing is that when we have a hypopyon, okay, hypopyons in the bacteria as well as in the fungus, so they are completely different. Bacterial hypopyons are always sterile as well as always mobile, while if I talk about the fungal hypopyons, these will be non-sterile as well as non-mobile. Non-sterile as well as non-mobile. Always remember about the hypopyons. Then this we have already done. Repeat here. Which of the following is true about optic neuritis? It is the RAPT, guys. Now see this question. Angle subtended by each optotype of 6x6 vision on a Snellen's chart. So basically they are talking about the minimum angle of resolution, which is 5 minutes of the hour. So they are talking about this. So basically what happens when you see the Snellen's chart, the distance of the patient from the chart is 6 meters or it is 20 feet. So in India, we will take it in meters, while in US we take it in feet. So 6 meters is equal to 20 feet. And therefore, if I talk about the normal visual acuity, either it is 6x6 or it is 20x20, anything we can say. And whenever we are talking about the visual acuity, suppose I talk about 6x60, okay. So this 6 actually is the distance. This is actually the distance of the patient from the chart. The distance of the patient from the chart is 6 meters, and 60 means the distance from which normal person can read this letter. The distance from which normal person can read this letter. So that means what a normal person can read from 60 meters, this person is reading from 6 meters. That is the concept of the visual acuity. Similarly, if I say 6x36, so that means what a normal person can read from 36 meters, this person is reading from 6 meters. When I say 6x24, that means what a normal person can read from 24 meters, this person is reading from 6 meters. meters. 6 by 18. What a normal person can read from 18 meters. This person is reading from 6 meters. 6 by 12. What a normal person is reading from 12 meters. This person is reading from 6 meters. 6 by 9. What a normal person can read from 9 meters. This person is reading from 6 meters. And finally 6 by 6. So what a normal person can read from 6 meters, this person is also reading from 6 meters, and that is why he has the normal visual acuity. Now, the thing is that each letter is actually visible to the patient. Each letter the patient is able to see. The normal person is able to see. That means each letter is making some minimum angle. So that is your 5 minutes of the hour. You have to remember that each letter makes the 5 minutes of the hour. That is the minimum angle, but at the respective distances. So that is very, very important, at the respective distances. So 5 minutes are made at the respective distances. Now respective distances means, if I talk about 6 by 60, so this will make 5 minutes at the 60 meter. Similarly, when I talk about 6 by 36, so respective means this will make 5 minutes at 36 meters. 6 by 24 means it will make 5 minutes at the 24 meters. If I talk about 6 by 18, then this is 5 minutes at the 18 meters. Then 6 by 12 hai, this will make 5 minutes at the 12 meters. 6 by 9 means we have 5 minutes at the 9 meters, and finally 6 by 6. That is, it will make 5 minutes at the 6 meters only. Okay, so this is the case. Now, if they are asking what is the angle made at 6 meters by 6 by 60 letter. Okay, now what you already know, that it will make an angle of 5 minutes at the 60 meters. This you already know. Now if he is not able to see from the 60 meters, he is going to closer 6 meters. Patient is standing at a distance of 6 meters. That means he is going closer by 10 times. So because he is going closer by 10 times, therefore angle will also increase by 10 times. 5 into 10, this is 50 minutes. So simply what you can do, you have to divide by 6 and multiply by 5, because 6 is the minimum distance and 5 is the minimum angle. If you can remember this, you can do question like this also. If you understand by the how much closer he is going, like if I talk about 6 by 36, so he will make an angle of 5 minutes at 36 meters. If he is having a visual acuity of 6 by 36, okay, then what is the angle made? So what is the angle made at 6 meters, guys? So now it is going closer by 6 times. Therefore, angle will be increasing by 6 times. That will be 30 minutes. Similarly, we can do it for 6 by 24 also, because here we are going from 24 to 6. So this is 4 times, because we are going closer by 4 times. So 5 into 4, this will give me 20 minutes. Then 6 by 18 के लिए we are going 18 by 6. This is equal to 3 times. Divide by 6 and then multiply by 5. You will get the 15 minutes. Then if I say 6 by 12, okay, 12 upon 6 is 2. 5 into 2, 10. So this will form 10 minutes. And finally 6 by 6 is equal to 5 minutes only. This was asked in INICET 2022. Please see if you have understood how to do this question. Any of the doubts in any of the questions? Any of the doubt in any of the question, guys? So we have done all the question, guys, and one thing I would say, that we have not done these many questions. We have done these many topics. We have done even topics more than these, because we have also discussed all the 4 options. So if I have done 30 questions, 30 into 4, 120, we have discussed 120 topics. Yes, if you are able to do these 120 topics, if you know everything about these 120 topics that is being told in the class, and you are knowing the images related to it, it will be sufficient, and you can easily do the questions of your INSET examination. Yeah. So, 1.5 syndrome. Okay. 1.5 syndrome. If I talk about 1.5 syndrome, it is actually due to the MLF lesion plus the PPRF lesion of the one side. So on the same side, I am having the MLF lesion also, and I am having the PPRF lesion also. So suppose I am making these eyes something like this. This is the right eye and this is the left eye. Okay, now you can see that if I am having the MLF lesion here, okay, because of the MLF lesion, we will have the ipsilateral ka adduction deficit, and we are have the contralateral abduction nystagmus. This you already know from your MLF lesion. So that means I will have absence of oh, oh. So we will have the absence of the adduction deficit on this side, as well as we will have the abduction nystagmus here. Okay, now due to this MLF lesion, it is also connected with the third nerve of this side. So this lesion is also gone because it was between third and the sixth nerve nucleus like this. Okay, so this MLF lesion is also affecting this one. So this has also gone due to the PPRF. Now this is gone. So this is half, that will be equal to 1, plus this is also gone. So this is half. Therefore, it is 1.5 syndrome. Only movement which is possible is actually the abduction with the other side. That is called as 1.5 syndrome. For the Park 3 step test, I have already discussed it multiple times, and also have given you a separate video for the Park 3 step test. You can please refer to that, and if you have any doubt, tomorrow again I will try to give you the this one on your Telegram group. We can discuss the different combinations, and we can be discussing the options. If you have any doubt in that, you can send me the screenshot of what you have done the solution. I will check to this and I will let you know in which step you are doing the problem. So I hope you have understood, guys. Now the topics like 1.5 syndrome, your junctional scotomas, we have the INOs, we have internuclear ophthalmoplegias and isocorias. There are so many things. Will not create a problem. All the very best for your INSET examination. Lage raho, do your very, very best. Keep on revising all the sessions, PDF you are getting. Keep on revising them, and I know that you will all come up in the flying colors. All the very best, guys. Happy ophthalmology. Bye bye.